even have high school students participating in the hackathon this year.
Nice.
Yeah. So I think we've got a number of attendees rolling in now. We're going to give it just a few minutes, and
Okay.
then I'll go ahead and do your introduction.
Okay. And will there be time for Q&A, or because I'm not sure that I can, I mean, I can fill a half hour, but I'm not sure if you want me to.
Yeah, we can definitely do Q&A. We have the webinar Q&A feature that people can use.
Okay, terrific.
All right. Welcome in, everybody. I see we've got people filtering in. Some of you have now come off, or most of you should have now come off your presentation sessions. And so exciting round one, and excited to hear from our finalists this afternoon. I'm going to go ahead and start recording, and we are live streaming to the YouTube for those who may be joining us there. All right, we're going to go ahead and get started today. Thank you all for joining the hackathon this weekend. We hope you've had fun working through these tough challenges and gained some new insights. I would now like to introduce our closing keynote, Dr. Marcella Alsan. Marcella is a physician economist studying the economics of health inequality domestically and internationally. She received a BA from Harvard University, a master's in public health from Harvard School of Public Health, a MD from Loyola, and a PhD in economics from Harvard. She trained at Brigham and Women's Hospital, Howard Hyatt Global Health Equity Residency Fellowship. Wow, that's a mouthful. Then combined the PhD with an infectious disease fellowship at Massachusetts General Hospital. Prior to returning to Harvard, she was tenured at Stanford. She is co-editor of the Journal of Health Economics, associate editor of the Journal of Economic Literature, and co-chair of the Healthcare Delivery Initiative of Abdul Latif Jameel Poverty Action Lab at MIT. She is co-recipient of the 2019 Arrow Award for Best Paper in Health Economics and the 2021 William G. Manning Memorial Award for the Best Research in Health Econometrics. Recipient of a MacArthur Fellowship, and was elected into the National Academy of Medicine in 2022. She co-directs the Health Inequality Lab at Harvard Kennedy School of Government. Thank you for joining us today.
Well, thank you for having me. I'm so incredibly honored to be asked to talk at this event, and I was able to join a little bit of the last discussion on health equity. It was truly impressive. What you all are doing, the mission that you have, and how you're using your skills, it's really, it gives me hope, and I'm sure so many other people. So thank you for having me. Thank you for organizing, and thank you to the participators as well. Can you see my screen okay?
Yes, we can.
Okay, excellent. So today I'm going to talk about representation and rules, and we'll start off defining a couple different versions of representation, and then we'll talk about rules, and then we'll talk about the feedback between the two. But feel free, I'm an economist as well as a doctor. I'm used to being interrupted. So if you have questions along the way, and I'll definitely want to spend some time on questions, whatever they might be, about research or just career path or whatnot. We'll try and save some time for that as well. Okay, so let's start off with thinking about representation. So representation is, in terms of an analyst, it's sort of like what is the mapping from the population to the sample? So how representative is the data that you're using to the underlying entire population that you might be trying to serve? And that's an issue no matter what country you're from, or if you're analyzing data and you're trying to use it for policy, and it comes out in both our surveys and in our census measures. Why it's so important is because we use these data for predictions, for forecasting, to run simulations, and then in applied econometrics, field I'm most comfortable in. We're typically taking a retrospective look, trying to understand what happened when the government rolled out this or that policy or whatnot. And so if we don't feel like we have a really accurate description of the underlying population using this sample, you typically don't think about the census as like a sample. It's supposed to be a whole count, but we'll see in a minute, it's really kind of gotten a little bit away from that, then we might be really worried that we could be getting the wrong answers. And that affects the allocation of resources in terms of both funding and congressional seats. And it also affects surveillance. So how are we going to hotspot? How are we going to know really what's going on? And you kind of saw that writ large during the pandemic. Now, there's another discussion of representation that I think is important, and that's representation when you're not really talking about just the mapping from a population to a sample or who's in your data in terms of what are the rows in the matrix, what are those observations, but we're actually thinking about the process, and we're thinking about who's in the room when we're talking about the question, when we're thinking about the approach, who's in the Zoom room, who's actually represented in the process, especially when that process is supposed to have an outcome, which is, let's say, a decision, whether that be a policy or maybe a discussion of whether, or actually a rule about whether something works or doesn't work in the case of a pharmaceutical agent or a therapeutic agent of some of some kind or another. And if people don't feel like they're reflected in that process, and this is true for science writ large, how are they supposed to think that process was legitimate? How are they supposed to feel that that process, really reflected their interests and what they thought was important? So I'm going to kind of think about that version of representation in a little bit later on, but I just wanted to let you know that I think of representation both in terms of representativeness of the data and then the who's in the room when we're talking about a process. Okay, let's get back to the data. So the United States is a wealthy country on average. And so you might think that our data, especially our census data, is kind of for sure completely representative. But we've had some issues, and some are longstanding and some are actually slightly getting worse. And when you think about who's counted and who's not counted, you have to remember, and I'm sure you all know this innately on some level, that a lot of that is also somewhat of a political decision, right? So those data units or observations are not helicopter dropped, they're financed and they're sought out to some degree or another. So we have a problem, for a longstanding problem, for undercounting Black men. This is the upshot is an article in the New York Times. Justin Wolfers is an economist out of Michigan. And you can just do basic demographic trends and you can say, wow, the sex ratio is hugely skewed for men who are working age. We just can't find Black men. And partly it's due to mass incarceration, but partly it's just they're literally not in the data for reasons that we can't explain. Then, of course, there was a big issue with respect to the 2020 census count here in the United States, where there's been an undercount of really all people of color. And then there's things that we just don't really have good data on at all when it comes to tracking violence against certain groups, and so on and so forth. So here's the undercount of the census. As I mentioned, this is kind of a long-standing problem, and the trend looks encouraging. So how do they actually know the undercount? That's a whole other process, but they try and audit essentially the count itself by going back to particular communities and seeing how much they've undercounted ex post. And here you can see that the trend lines might look encouraging, but the gap is actually still very persistent and pretty much unchanged since the 1960s, which means that if you're using this to allocate, you're still disproportionately not directing resources to one particular group versus another. And yes, a negative undercount means that you're overcounting. So that's the undercount kind of by race in our census in the United States. Here's it looking across locations. And again, when you think about the political economy of this, we're seeing a concentration of the undercount in places in the South, which tend to be controlled by the Republican Party, but not just in the South. It's really kind of spread out around the country as well. And this is the Black population undercount, but there's also an undercount in terms of just socioeconomic status. So if you break things down by individuals that rent versus those that own, we see that there's an overcount, if you will, of owners of households and an undercount of individuals that are renters. We can also look at it by age. There tends to be an undercount for children, and the younger the child is, the more likely they are to be missed. And that, of course, has huge implications for trying to allocate, programming for children and for mothers that are pregnant. What's been happening over time? So I showed you those kind of declining trends overall for Black and white, but I think that actually stopped, in 2010. So this is now looking 2010 to 2020. And unfortunately, 2020, obviously there was a lot of political rhetoric about potentially putting a citizenship question on the short form. And I think we saw this dramatic increase in the undercount for Hispanic and Latino individuals. We saw also an uptick in the undercount for AIAN individuals, and also an increase in the undercount for Black or African American individuals, whereas a slight overcount for non-Hispanic white. So this has been, again, an issue of concern if you think about, and we'll talk about in a minute, all the ways that social scientists like myself and data scientists, like I assume many in this Zoom room are, might actually be using data like this. And again, I don't think this is necessarily specific to the United States. I think we all have to think about, the data generating process. So as I mentioned, the census is usually decadal for all of their countries of origin too. They're probably every 10 years doing a census around about. But in the United States, we also do something called the American Community Survey, and you might have a similar one in your country if you're not from the United States as well, where you try and get a sample within, you don't want to just have data come in every 10 years. You try and get a sample on an annual or a more frequent basis. So this is our American Community Survey. And here you can see these coverage rates, and the definition of that is down below. And again, in these annual surveys, we've seen, again, a coverage rate which has been going down for Black and Hispanic individuals. And when we look at response rates, these are kind of due to some administrative and fiscal crises, but the overall trend has been downward, with people just refusing to answer some of the questions, to answer the survey whatsoever. And so those are sort of pretty worrying trends. Now, why, again, census representation might be particularly important or particularly concerning for us is that it really affects the accuracy of everything else. So often all the other surveys that one might use are based on census sampling, and they weight respondents based on census counts. So in economics, that would be the survey of income and program participation, the general social survey, the current population survey. All of these kind of estimates that we use for our economic statistics are kind of based on census weights. Not only that, but when you're trying to understand equity implications of policies and programs, you might also be linking to the census. So in particular, after this Social Security Administration discontinued publication of race and ethnicity, researchers who were interested in Social Security linked disparities or related ethnic and racial disparities linked to the surveys that are derived from the census or the census itself to understand race and ethnicity. So again, if you have a problem kind of in the census, it trickles down to everything else. But in addition, to the extent that these surveys are also facing some of the problems that the census faces, we're going to just see a magnification of those underlying data quality issues. So we saw that response rates were non-response rates rather were going up over time, and so this was a experiment that I carried out with some development economists at MIT. So Abhijit Banerjee and Esther Duflo, who recently won the Nobel in economics, as well as Ben Olken, who's at MIT, and then myself and Emily Breza, who are at Harvard. and Paul Goldsmith Pinkham, who's at Yale. Anyway, we were interested in this issue of response rates and how could we get individuals to respond. So we tried two different framings. We were working with the government of the state of Minnesota, who was actually knew they had this problem. They were trying to actually track the pandemic. This was pre-vaccine, and they didn't have a good sense of who kind of actually had been infected or what kind of information people had. And they just wanted to run a survey amongst individuals coming for food, to the food shelves for food handouts, food to help with food insecurity. And so we tried two different flyers to distribute at these food shelves. We randomized on the food shelf date. So it was kind of a huge undertaking where we distributed these flyers in a hygienic way to every food shelf on every day. And then we collected them at the end to see actually how many had been taken. And then we could see how many people actually used the flyer and logged into our survey. So this was either the state of Minnesota wants to know how COVID-19 is affecting you. And then we asked, how is COVID-19 affecting you? Share your experience. So one kind of emphasized the role of the state. One, in here it says again, the state of Minnesota, and one actually emphasized the role of academics like us in trying to collect this information. And we had Spanish versions of this as well, so we translated it into Spanish, and we cross-randomized the framing, so government versus researcher, with financial incentives, $10 versus a more high-powered $20 incentive just for logging in and answering the survey. And so this was all a randomized experiment. So what did we find? So here's what we found. First of all, the take-up was pretty low. But at least in the low incentive framing, just by saying that we were researchers versus the government, we were able to double the take-up. So take-up here is actually, we're not even, we're not taking up a product. We're just actually seeing, will they respond and log in to answer our survey, right? So at the $10 incentive, we were able to see 10% of individuals that received a flyer actually logged in versus only about 5% in the government framing. And that's all that was different, was just basically who was asking, right? So what do you think happens when we actually upped the incentive to $20? So this is why I love research, because you never know what you're going to get. So this is what we got. So in fact, under the high incentive, we could really up the response rates for individuals who saw the government frame. Whereas in the researcher frame, we were still at that 10% mark. We kind of topped out at that 10% mark. Then this is where you have to get into the psychology of, why is it working? Why is the higher incentive working to kind of increase? What makes the government framing elastic to monetary incentives is one way to frame it, and the research framing somehow inelastic to monetary incentives. You might think that maybe people who are attracted to answer for research purposes are just going to answer no matter what, whereas people who are going to, thinking about government and the sort of trade-off, I give you the information, you give me something in return, might actually be more elastic to monetary incentives. The bottom line is we're still looking into this, but it's kind of exciting that we can increase the response rates. Now the question is, we can increase the response rates on the extensive margin. Fine, they answer the survey, but what does it do to the way they answer the survey questions? So that's the item response rate. And you want to make sure that the incentive doesn't interact with that, right? Okay, but the truth of the matter is, in all my field work, because remember, I'm a doctor and an economist, and so it's just incredible how many people tell me that they've never answered the census. They've never filled it out. So if we look at our Minnesota experiment, we see this huge gap emerge. Overall, only 42% said that these are our food shelf participants. So these are poor individuals. So you should think about race crossed with poverty, but the poverty is pretty much present to some degree for both our Black and white participants, because these are people that are recruited, trying to pick up food during the time of the pandemic. Anyway, there's an 18% racial gap. On an online Qualtrics panel survey. So this is an online survey. It's about 4% percentage points, I should say. So those are huge gaps. And obviously it's different on online because that's a self-selected kind of, those are individuals who have access to the internet. But I just want to put this in perspective. Minnesota tends to do pretty well on the census compared to the national response rate. So what about health data? One of the sort of unintended consequences, or whatever it might be, because we lack a national health system, we are dealing with very imperfect and oftentimes proprietary health data. Proprietary means it's owned by a private entity. And so in order to be able to use it, researchers have to pay a lot of money, or they have to kind of work with industry in order to get the finger on the pulse of what's happening to the health of Americans. And that is actually one of those things that I think is actually was really costly during the pandemic, and continues to be very costly for us to really understand how the health of the population is doing. So yes, there's, Medicare, which is an interesting setup, that once you turn 65, all of a sudden the government becomes the payer of last resort, is the absorbing state for all of these funds. But in fact, a lot of that has gone into private entities now with Medicare Advantage. There's the Veterans Affairs, or TRICARE. These are predominantly male samples of individuals that have been served in our military. Active military is in TRICARE. Veterans Affairs are individuals that used to serve in the military. And that's also, though, a selected sample. Not only is it selected primarily on gender, but it's also selected based on the fact that some veterans that are maybe better off don't actually use the VA. And then even something as simple as, what you died from, mortality, surely that has to be sort of accurately recorded. But the truth is that, in fact, in much part of the United States, all of these parts in green, we actually have coroners that are elected. They can be partisan. Whereas in the rest of the states, we actually have medical examiners who are appointed and basically use their specialized training. And this is all very suggestive, but it's just here when we're looking at COVID deaths, what fraction of all deaths were actually assigned COVID-19 versus some other cause, we can actually see that in places where the person was an elected official, that the death rate assigned to COVID was actually quite different than in places that had a medical examiner. Okay, I see that I'm almost, I could go through more of this, but I think, obviously we have, for the amount that we spend on healthcare, we had not a great response to COVID. And I think we're obviously that it's just on average, we lost a lot of life expectancy, and across different groups, we lost even more, which was really, really concerning. In terms of the loss of life expectancy. I think it's caused a lot of health economists to sort of rethink the role of the healthcare system in sort of at least not alleviating, if not somewhat exacerbating, some of these problems. The last little bit I wanted to tell you is about that second part. What does it mean to be part of the process? And this, I'm just going to use the example of being represented in a clinical trial. So clinical trials take as their inputs patients. And at least when we're using the clinical trials database, which you can find online, which includes basically all of the clinical trials that have been registered by anyone that really wants to seek FDA approval, which is pretty much everybody. So you have this registry, and you can just see that, this is primarily, most experiments are being done on white versus Black populations. And in fact, most of new drugs, this is what the right-hand side shows, most of the new drugs, this is relative to year of approval, are also being given to white versus Black patients in the United States. So we did a simple randomized trial. We did it at both the physician and the patient level, where we took Black and white patients, and we actually found a drug, an antihypertensive drug. So these were all patients with hypertension that had actually broken out their data by how did it affect Black patients and how did it affect white patients. It seemed to actually work equally well amongst both sets of patients. But we were able to actually say, well, here's a sample that is primarily white, and this is a sample that is actually a bit more racially diverse. And so we were able to use the hold efficacy constant and just vary the characteristics of the sample, if that makes sense, whether it was more diverse or really not diverse at all. And that we actually just grabbed from the clinical trials registry online. For the physician experiment, since physicians are the ones prescribing the meds themselves, we actually had to kind of invent some experiments because we just didn't have the racial diversity that, naturally occurring that we could leverage. And so what we did there was we asked them, what are the types of patients you see? So actually quite a few physicians don't see barely any Black patients, and some see a more significant amount. And we hypothesized that for those who really don't see any Black patients, they might not really even matter to them what the sample looks like. But for individuals that actually are trying to take care of patients of color, they might actually worry if a sample is not more diverse, thinking forward to how will they convince someone to try something new, and maybe even anticipating those sorts of questions. So 3 more slides and then I'm going to end. So here is just for the physicians, we did diabetes drugs. So we looked at how efficacious, we randomized how efficacious the drug was, and that was by how much it lowered your A1C. And then we asked them, okay, now you know this about how efficacious the drug is, how likely would you be to prescribe it? Okay, so we gave them sort of scientific information. And lo and behold, and this is very good for physicians in America, that the higher the efficacy of the drug, meaning the more it took care of somebody's diabetes, the more likely the doctor was to say that they would prescribe it. But this was for physicians that mostly treated white patients. When we actually took physicians that treat some Black patients and we asked them the same question, and we gave them a sample that was non-representative. So this drug was tested on a sample of primarily white patients with very few Black patients. They have the same slope, meaning that the more efficacious the drug, the more likely they would to prescribe it, but it's just shifted down. But interestingly, when we actually make the sample more representative, we can close those racial gaps just by inclusion of people in the process. And we were able to show the same thing on the patient side. So the gaps exist between Black and white patients in terms of their willingness to try the drug, when the samples are not representative, and those gaps can close when you give a representative sample. So I won't have time for rules, but I would just say, if you're not in the room, how can you make the rules, right? And the rules are also incredibly important and have this feedback loop. Who's in the room determines the rules. Who's making the rules determines who gets in the room. and we see this time and time again. So data are a living thing. Think about who's missing and why, and make sure when you're thinking about the questions and you're thinking about the data, who's in your Zoom room, who's informing your questions, and how can you bring their voices into the discussion to give more legitimacy to the great findings that you're going to discover. Thank you so much.
Thank you so much. Looks like we did get one question in the chat. How reliable is the process of sampling a pandemic, particularly when focusing on the center as opposed to considering the entire global population?
I think this is a huge question. I think the fact that Johns Hopkins kind of emerged as the authority in tracking the pandemic is fantastic for the researchers at Johns Hopkins and the resources they have there. But it's also a little bit of an indictment on our ability to do global health surveillance more broadly. I think, just again, we can think about it as enlightened self-interest. We should care about what's happening to the health of poor populations in the United States and abroad not only because it's sort of a moral imperative, but also because with the climate change and ecosystem destruction, we're going to see more and more emerging and resistant organisms, and we should probably know about that more in advance.
Awesome. Well, thank you so much. That's our time for today. I just wanted to thank you again for being with us and those fantastic remarks.
I want to thank you all again for the work that you do, and feel free to reach out to me at Harvard, whenever. Thanks again. Bye, everyone.
Thank you. A reminder to all of our participants, the final judging round will start in half an hour at 2 p.m. Eastern Time. At least one member of your team must be present, and finalist teams will be notified 7 minutes before their presentation time slot. We will then announce the winners of each challenge starting at 4:15 p.m. Eastern Time. Thank you very much.